session. And then I just want to also emphasize again that we've stopped with the QR codes on the app, but we will issue certificates at the end of the series. So if you at least join 60 to 80 to 70% of the sessions, you will get a certificate from us. And also, if we can just maybe ask, when you register for the webinars, please use your private emails, as we see that some of the work emails keep on bouncing back. So it would really help us if you all register with your private emails when you enter into the registration for the webinars. And then just for myself to hand over, I'm going to ask Dr. Edouard Latif from Africa CDC to give us an introduction on the COVID status, and then I'll stop sharing my screen so that he can start. Thank you. Over to you, Dr. Edouard.
Thank you very much, Anna, and good morning, good afternoon, good day to everyone on the call today. You are welcome to second session of our series 4 of infection prevention and control. Let me quickly share my screen. Kindly confirm if you can see my slide.
Yes, we can.
Thank you very much, Hannah. So today my presentation is in 2 parts. The first part is the epidemiological situation of COVID-19 globally and across Africa continent. The second part is going to be on the newest initiative that CDC, African Union just roll out this week. So this slide shows the epidemiological situation of COVID-19 globally. And the map to the left shows the distribution of COVID-19 cases by country across the world. The darker color indicates the countries that have reported more than 300,000 cases since the beginning of the pandemic. And 20 countries, including South Africa, have reported over 300,000 cases to date. The panel to the right shows the epidemic curve. And this is showing the trend of COVID-19 cases reported daily by the 6 WHO geographical areas. The PAO region in yellow is still reporting the highest number of new cases by day. And Africa in the dark red color currently accounts for about 4.5% of all COVID-19 cases reported globally. Overall, more than 35 million confirmed cases have been reported, resulting in over 1 million deaths with case fatality rate of 2.9%. This slide shows the trend of COVID-19 cases from February to date. The epi charts depict the number of new cases on the y-axis and by day, reported by day on the x-axis. And the 7-day moving average is shown by the red line. Over the past 4 weeks, the number of new COVID-19 cases being reported per week has decreased. And overall, more than 1.5 million cases have been reported across Africa, with more than 37,000 deaths, resulting in case fatality rate of 2.4%. The good news is about 83% have recovered. This slide shows the table of the distribution of COVID-19 cases, deaths, recoveries by African Union region. And over the last 24 hours, about 6,863 new cases have been reported, of which the Northern and Southern African region reported almost all these new cases, with new deaths of about 81, and the recoveries are over 5,000. This slide shows the cumulative COVID-19 cases by African Union member states as at 7th October, 9 a.m. East African time. This map, we can see 24 countries are reporting less than 5,000 cases. 5 countries have reported between 50,000 to 500,000 cases. And only one country, which happened to be South Africa, have reported more than 500,000 cases. This slide shows the total COVID-19 tests conducted in Africa between 14th of February till 7th of October. More than 16 million tests have been conducted, with 10.5 tests per reported case and 9.5% positivity rate. So let me shift gear and move to the newest initiative that was launched and rolled out this week by Africa CDC in collaboration with World Health Organization, the regional economic communities across the continent, and other partners like UNICEF, ICAO, and others. This initiative is tagged Africa Against COVID-19, Saving Lives, Economies, and Livelihoods. And we have 3 goals. The first is protecting borders and travel. Second is protecting economies and livelihood. And the third goal is protecting schools. So the first goal, talking about protecting borders and travel, has this objective of how to minimize the spread of infections within and across the borders by creating a public health safe corridor for safe travel. And to achieve this objective, we have these 3 items. First is to harmonize and certify SARS-CoV-2 testing for border crossing, supported by the PACT initiative. If you can recall, PACT initiative is a partnership to accelerate COVID test initiative that was launched and rolled out in April this year by Africa Center for Disease Control and Prevention. The second is e-health networks using mobile apps and digital tools for SARS-CoV-2 contact tracing. And lastly is a cross-border information exchange to facilitate effective response. The second goal is protecting economies and livelihoods. And the objective is to minimize the impacts of COVID-19 on economies and livelihoods. To achieve this objective, we have 3 items. The first is employ technological digital tools to assist, enhance surveillance and contact tracing at businesses and touristic sites. Second is to generate data to understand the body and assist focused interventions. And lastly is a risk communication to address the misconception and infodemics. As you are aware, there are so many misconceptions and infodemics concerning this COVID-19 pandemic that we are dealing with. The last goal is reopening of schools. As we cannot continue to lock our children and our institutions at home, all because of this COVID-19 pandemic, we need to look at how we can open schools safely. And the objective is to ensure that schools are reopened safely. So to achieve this objective, we have these 3 items. First is to scale up PACT initiative to assess the risk of SARS-CoV-2 in the community to inform additional protective measures. Second is to enhance this initiative and surveillance of SARS-CoV-2 at school premises to minimize transmission. And lastly is to enhance public health measures to protect students and staff. Thank you very much.
Thank you very much, Edouard. We really appreciate that. It's great to see what has been going on. I'll then like to introduce Amy Elizabeth Barrera Candisa, but I'm sure Amy will be able to tell you exactly who she is because it's quite difficult to pronounce her surname. She is an IPC specialist with AFRA, and she's also a nurse by training with a background in infectious disease epidemics. So Amy is going to take us today through healthcare safety for the healthcare workers and for the environment. Welcome, Amy.
Thank you, Anna. Thank you very much. I appreciate it. And good morning, good afternoon, good evening to everyone. Thank you so much for attending the session today. As Anna mentioned, my name is Amy Elizabeth Barrera Cancheda. I know it is a mouthful. I'm Mexican, so I've got quite a long surname, but most people just call me Ebeth. So please feel free just to call me Ebeth, short for Elizabeth. I work at WHO Afro within the Department of IPC, and my specific area is actually healthcare worker safety during epidemics. Unfortunately, this is my 7th epidemic here on the subcontinent. Mostly I've worked in Ebola and Lassa fever and Marburg. But there are some great similarities amongst all epidemics, especially trying to address healthcare worker infection and health worker infections when doing so. So I'm going to share my screen and I'm going to take us through what I think is some delicious content this morning, but you can decide what you think. And then, of course, ask me any questions you would like towards the end of the presentation. I am going to talk extensively around using multimodal approaches with implementation strategies that we know to be effective strategies to promote infection prevention and control, to promote healthcare worker safety during this COVID-19 pandemic. So I'm going to turn my video off just for a few minutes because I don't want to continue to scare all of you during my presentation. But then, of course, I'll turn it back on in a few minutes. Can everyone see my slide deck okay?
Yes, we can.
Okay, perfect. So the first thing I always like to do is I like to be very interactive with participants. I like to engage and I like to talk to you a lot. So the first thing I wanted to ask before I started to go into the content, and please just feel free to write your response in the chat box, is can anyone tell me what they think implementation science or implementation strategies are? What are they? What is this implementation discipline or implementation strategies that we use to try to promote certain behaviors? Can anyone tell me? What do you think it is? Now, I know you guys are not shy. I've been on many trainings and I know you have lots of thoughts and lots of comments. So can anyone tell me, what do you think sort of implementation science, implementation strategies really are? Okay, addressing implementation problems. Exactly, that's one very important component. What else? What else do you think? Is it just implementing random strategies, just any strategies that we think will be effective? Or should we be a little bit more methodical about which strategies we choose to implement? Yes, so very, very good. So we use implementation science. I'm seeing some really delicious responses now. Evidence-based strategies, solution for action, very, very good. So yes, we use implementation science and the specific implementation strategies to be able to promote evidence-based practices. And really, infection prevention and control is the most obvious of these in terms of using strategies to be able to implement hand hygiene, mask wearing, physical distancing, these types of things to be able to ensure that we're reducing the transmission of COVID-19. Now, specifically, just to give you a very brief overview, and I won't spend a lot of time on this, but I wanted to just show you what we're going to talk about today. So I'm going to introduce you to the discipline of implementation science just very briefly, just so that you sort of understand sort of the strategies that I'm going to be talking about a little bit later. I'm going to talk a little bit about the strategies that we can use specifically during an epidemic or a pandemic. There's sort of 6 categories of strategies that we have to use, multiple ones, in order to effectively address and reduce transmission of an infectious pathogen. Then I'm going to talk about how you can design an intervention for healthcare worker safety using these implementation strategies. And then last but not least, I will share with you a set of tools that we've developed at Afro that you can use in conjunction with other tools that ICANN and Africa CDC and other partners have developed to be able to do effective surveillance when you actually do have confirmed cases of COVID-19 amongst your health workers. So very briefly, here's sort of the boring sort of technical definition of implementation science, and that it's a specific area of inquiry or study of the methods that can be used systemically, essentially, to promote evidence-based practices. So essentially what implementation science does is that it uses strategies to bridge what we know and what we do. So how many times have we been working in healthcare facilities and we'll go around, we do assessments, and we'll talk with health workers or we'll talk with administration or leadership at the healthcare facility, and we quickly realize that it's not a lack of knowledge that keeps us from promoting IPC strategies and keeping health workers safe. It's really sometimes more about behavior change in what we do. So, as a nurse, I would challenge all of you to go into any healthcare facility and ask a nurse, do you know about hand hygiene? Do you know how to wash your hands? And they'll probably look at you like you're a little bit of a nutter, right? Because the reality is that we all know about these things. The challenge is, particularly during epidemics, especially during epidemics, or in this case, pandemics that go on for long periods of time, it's human nature to become a little bit complacent around ensuring that we are doing what we know we should be doing. So I'm going to talk a little bit about this very thing today, all right? Okay, so we all know what evidence-based practices are. These are ones that are rooted in scientific scholarship that have been shown to be efficacious at reducing infectious disease within IPC, of course. Now, there are lots of evidence-based practices in medicine and nursing writ large, but the ones that we talk about a lot in IPC are, of course, your standard precautions, your transmission-based precautions, and then, of course, last but not least, our administrative precautions, okay? So here we go. When we have an epidemic or a pandemic, as we're experiencing currently, there are 6 buckets, so to speak, or 6 categories of implementation strategies that have been shown to be effective at being able to promote and implement successfully evidence-based practices that lead to health worker behavior change. Now, you might be saying, Ebeth, okay, just 6 strategies, just that's it? We just do these 6 and everything's gonna become magically wonderful? No. So there are 6 categories of strategies, but there are lots of different strategies within each of these categories, and I'm gonna give you some examples, okay? So let's start with the one that probably most of us are kind of familiar with. But before I start talking about the individual strategies, can anyone tell me in the chat, what is the implementation strategy that we focus on the most in general during an epidemic and a pandemic? There's one category out of these 6 that we hyper focus on during an epidemic and pandemic. Which one is it? Exactly, education. And I saw someone even get more specific, training. Well, training is a type of education strategy, and we're going to talk about that. Education is a critical component during an epidemic to ensure that our health workers, our communities are well aware of not only the disease that we're addressing, but ways to keep you safe. The challenge is that we know education alone, training alone, does not change behavior. It's only when an educational strategy is combined with one or more, I should say, of these other categories on the screen that we can actually start to really implement effective change, okay? So I'm gonna talk a little bit about this education piece because we do focus on it a lot during epidemics, and we have to be careful sometimes not to over-rely on it. Okay, we have specific implementation outcomes we are interested in when we are implementing strategies during an epidemic or in clinical practice. Some of the outcomes we are interested in are implementation outcomes. Can we feasibly implement hand hygiene? Is it acceptable to health workers the way we implement hand hygiene? There are also service outcomes that we are interested in, right, around efficacy, effectiveness. The thing is with a lot of our IPC evidence-based practices, we already know that these are effective and efficient practices. So we may not focus as much on the service outcomes during an epidemic as we would on, let's say, the implementation outcomes. But we are interested in clinical outcomes. Are our patients getting better? Are we seeing reductions in actual cases? What does symptomology look like? Are health workers satisfied with the way that various EBPs are being implemented? So here are just a few categories of outcomes that you can measure when you're implementing strategies around IPC and other clinical services. Now, I wanted to show you what this looks like. All right, so that way you can have a framework for how this would work. So in IPC, we have evidence-based practices, right? Standard precautions, transmission-based precautions, administrative precautions, all of these are actual practices that we know are effective at reducing the transmission of an infectious pathogen. And the way that we promote these evidence-based practices, ideally, is through using implementation strategies. So that's more than one of the 6 categories of those strategies I just showed you. And our goal is that when we effectively implement these strategies, we're going to be able to see positive outcomes, either implementation outcomes like feasibility, acceptability, service outcomes like effectiveness and efficacy, or again, clinical outcomes. Oops, I have a typo. Clinical outcomes around satisfaction, function, health, patient outcomes, things of that nature. So this is a framework that has been adopted from Proctor, who's obviously a very well and famed implementation scientist, but just to show you that this is sort of the framework in which we would use in IPC to effectively implement these evidence-based strategies. Let me change here. Okay, so let me give you a further example, because a lot of times people say, Ebeth, I'm starting to understand what you're saying. So we have the 5 moments of hand hygiene. So hand hygiene has been critical. It is critical on a good day, and it's very critical during an epidemic or pandemic. So this is our evidence-based practice. This is the one that we want to promote in our healthcare facility, because we realize that amongst our health workers, there's maybe poor compliance, limited adherence, maybe there's infrastructural or resource challenges around implementing hand hygiene. So we want to try to do our best to implement this EBP. We're going to take our EBP and we can use something like a multimodal approach. That this is one that WHO has developed over the years. And we can use all of this to actually improve. Let me go ahead and show you here. We can use a restructure policy, which is an implementation category I talked about, where we are planning for system change. So we want to decide, we want to put alcohol hand rub at the point of care. That's a restructure policy, and that we are going to modify the physical environment to be able to make implementing the EBP easier. We might also decide we need a planning strategy before we implement anything. So we want to assess, how safe is the environment to actually introduce something? How much modification are we going to actually need? Then, of course, we must have training, right? We have to have an educational component. We have to be able to share with our health workers and patients that why we're now putting alcohol hand rub, how long to wash, how long do we need to rub our hands for, what percentage of ethanol needs to be in the hand rub. Then, of course, we want to make sure that we're doing quality management. We want to make sure that once we've implemented our strategies with our EBP, we want to make sure how well are we actually doing, right? And then, of course, we have a few others at the end here, which are education related. And once you've selected the IPC practice you want to implement, and you've decided which strategies you think are going to be the most effective for your context, once you combine these two things, you are hoping to then show an improvement in outcomes, depending on the outcomes that you want to measure, right? So it can be implementation outcomes, clinical outcomes, or other outcomes that we have discussed. So I want to take a pause for a moment, and I want to make sure that this example was clear. Does everyone understand so far what I've been discussing a little bit? I just want to make sure. And I'm happy to review anything that is not clear. Let me go back. Okay, so now this was just one example. I'm going to continue, and we're going to talk a little bit more about individual strategies under each category that you can use to implement an IPC practice or practices at your healthcare facility or at different levels of your healthcare system. So here they are. Here are the 6. So the first one we're going to talk about, everyone's familiar with this strategy, education, right? And here are a few examples that we can use to try to promote IPC practices. So we can develop materials. All of us have been very rapidly developing technical guidelines, educational pamphlets, posters. All these materials we have been developing to ensure that communities, health workers understand what exactly is this COVID-19 virus and how do we try to implement IPC practices to keep us safe, okay? We've been training health workers. We've been doing demonstrations, re-demonstrations, didactic sessions with theory and practice, on-site mentorship, all of these things we have been doing all of these things are things that we would routinely do during an epidemic or a pandemic to ensure that individuals are aware of the potential educational strategies that can be used. Now, as I had mentioned, education alone will not get us where we need to go. You can train health workers all day long about the importance of hand hygiene. And the reality is that the educational increase in knowledge between the first time you gave them a training and a second time you give them a training, let's just use the example of hand hygiene, the actual information is going to actually increase minimally. Because after a while, after you've provided so many trainings, health workers are obviously brilliant. They know what exactly they need to do. The challenge lies in how do we go one step or two steps further to make sure that we're doing what we know in practice, okay? So let's talk about some of the other strategies that you can use and pick from in order to accompany your educational efforts. One is, of course, monitoring and evaluation systems. All of us have rapidly tried to implement different ways that we can collect data to ensure that we are actually achieving goals that we set out. But there are also other strategies that sometimes we will forget when we are in emergency situations because we are so overworked already. So for example, one of the most effective quality management strategies to use during an epidemic is to give real-time feedback at the bedside of a health worker. Now, sometimes this will be called mentoring or, clinical management and education, but really it's at the point of care, even during an epidemic, where giving real-time feedback is really, really essential. Because the majority of our practice is going to happen when we're delivering patient care. It's not going to be when we're taking tea break in the cafeteria at the hospital, right? So making sure that we are keeping our strategies, particularly quality management strategies, at the point of care as close to where the problem is paramount. You also want to make sure that you are re-examining your implementation. If you start to see that something's not working, it is perfectly fine and expected that you would make a tweak or an adaptation to make sure that the implementation strategy can work for your context, okay? And then here are some others about providing clinical supervision and using data warehousing techniques. Now, I will let you know that these are just a few examples under each of the implementation strategy categories. There is an exhaustive list of 72 individual and unique strategies that you can use to implement evidence-based practices, and I have provided that link at the end of the training if you want to look at the complete and exhaustive list. Next but not least, before we start implementing anything, the one thing that you want to do is you want to see, based on your healthcare facility or your country context, what strategies are actually going to work for us. Your strategies are really going to depend on, are you working in a large tertiary healthcare facility or are you working in a smaller sort of CCC out in the community? You want to start to develop what we call an implementation blueprint. You want to start planning out your strategies based on your context, and then in your blueprint, also make sure that you have a plan to scale up activities. So in implementation science, we like to start out a little bit slow, make modifications, and then once we have the modifications, expand up exponentially. And I'll talk a little bit more about that. Of course, we can't do anything without having our buy-in, which is very important in terms of local consensus and making sure that leadership and our community authorities are well aware of our strategies. And then, of course, establishing relationships. You know, none of us can work an epidemic or a pandemic by ourselves. So the one thing that we have to do is to make sure that we can lean on other external partners, which all of us are doing right now, to ensure that we are able to comprehensively implement strategies. The one thing I always like to emphasize is that the government alone will struggle to implement all of these strategies on their own, which is why sort of having effective partnerships so that different strategies can be taken on by different partners if needed can be done so. Restructure. During an epidemic, it is inevitable that health worker roles and responsibilities will be restructured. It's very important to already have an idea based on your healthcare facility and the context that you work in, what those revisions will look like. So some nurses, for example, may be pulled to work only the triage bay. Some clinical doctors may be pulled to only work at the COVID-19 healthcare facility. So, deciding in advance as best as you can what the restructuring of professional roles are going to look like is very important. Also, during an epidemic, you want to develop clinical teams well before a case of COVID appears at your healthcare facility, but you can still do this if you haven't done it already. You want to identify health workers that are okay with not only having their professional roles shifted, but also be voluntarily willing to be a part of the COVID-19 sort of emergency response team at your healthcare facilities. One mistake that happens many times in epidemics is that health workers are forced to work in clinical settings and clinical contexts that they may not feel comfortable with. And we know, based on the literature, that if a health worker does not feel comfortable working in a specific context, then they increase their risk of infection during that epidemic, okay? And of course, restructuring can also look like changing the physical environment, and then of course, implementing novel data collection systems if needed. Finance, another interesting strategy that we use during epidemics, and it is a bit of an ethical one, but it's one that is definitely amongst the strategies that can be used, would be to provide financial or non-financial incentives to health workers as a form of hazard pay or compensation during the acute emergency. Or finding other new ways to fund initiatives is also very important. And then last but not least, of course, policies. And this one kind of goes without saying. We've all been rapidly developing these TORs and SOPs very quickly during this pandemic to ensure that we have some standardization and some consistency around guidances. So that was a very sort of quick, if you will, introduction to the 6 categories of implementation strategies that can be used to keep health workers safe from COVID-19 and other infectious agents when they're used in combination to promote infection IPC evidence-based practices. So what I'm going to do now is I want us to think about an intervention. I want to think about, I'm working at a healthcare facility and I've realized that healthcare worker infections, they're increasing at my healthcare facility. And I realize that I have to develop an intervention now for IPC to try to reduce health worker infections in my facility. Now, I'm well aware that unfortunately, because this is a pandemic, there are some health worker infections that are happening in the community. What I'm talking about here is an intervention that we want to implement at our healthcare facility to try to address facility-specific IPC challenges in order to just reduce any potential infection that might be occurring at the healthcare level. So I want us to think about an IPC evidence-based practice or a couple of them that we want to implement in our facility so that we can develop an intervention, because we're starting to see an increased number of health worker infections at our facility. So the first thing that you want to do is you want to think of, what are some of those challenges? What do you think potentially are contributing to health worker infections? Is it the fact that you don't have required PPE resources? Is it because the PPE is being used incorrectly during an AGP, an aerosolized generating procedure? Is it that people are forgetting to actually use resources, or are they actually not adhering to the evidence-based practice to fidelity? And it's probably going to be a combination of all of those things, right? So the first step before you think about your intervention and the strategies that you want to use in your intervention is to do a quick assessment of what are your challenges. The second thing, and it's a step that many people forget, is what have you already done? We've all already tweaked and modified different techniques in our healthcare facilities to effectively address challenges. So make sure that you're also keeping a running tab of what you've already done to ensure that you don't necessarily repeat a strategy that you've already used, which is very easy to do, particularly during an epidemic when there are so many players having a seat at the table. Then you want to do very quickly a quick assessment on what resources do you have available to you? What resources are you lacking? And very quickly do a quick assessment on that. The fourth thing that you want to look at is your infrastructural and engineering challenges. I can assure you that in our region, one of the biggest sources of challenge that we have during an epidemic is our actual infrastructural challenges. Either we don't have sufficient infrastructural capabilities in our health facilities, or we have very limited space to actually perform the activities that we need to perform. Number 5 is, how is health worker morale? Everyone says to me, Ebeth, this is so crazy. What are you talking about? Now we have to make sure that healthcare workers are okay and their mental health is okay? Absolutely. This is a very important component before you start to implement strategies in an IPC intervention, because we know from the literature that when healthcare workers are not doing well in terms of morale and feeling that they are empowered to actually implement IPC practices, they are at increased risk of actually getting the infection. Doing a quick assessment, seeing how health worker morale is going to be very important, because you may find that if healthcare worker morale is poor, one of the strategies that you might want to implement might be an incentive strategy. For example, you might say, you know what? Once a month at my healthcare facility, I'm going to buy lunch for my health workers just to let them know that they are appreciated. And that might be a strategy you have to use. One of the things I hear from health workers in every epidemic I've ever worked is that I feel overlooked, overworked, and under-recognized. All I would like is for someone to come and say thank you for what I'm doing. It could be as easy as doing an incentive strategy for your health workers by having the chief medical officer and the chief nursing officer walk around to each of the wards for each shift at the healthcare facility and simply say thank you to the staff. That is actually have been one of the most effective implementation strategies I have implemented in previous epidemics. And you can see it's cost effective and it doesn't take up much effort. Is there a strong administrative and political commitment to change? I'm no fool, ladies and gentlemen. I know that sometimes health workers actually know more about IPC and what they need to do and all of the things that are challenging at the environment than sometimes leadership might know. I know it's an unfortunate reality of sort of healthcare systems in general. So making sure that you actually have some political will to change and have things change is also very important. And then last but not least, how have healthcare facility operations or service delivery changed since you've had your first COVID case. So obviously, the longer epidemics and pandemics go on, service delivery platforms also have to change. So how has care and service delivery changed before you've actually, while you've started dealing with cases at your facility? These are the top 7 considerations you must think about before you start thinking about which types of strategies you want to use to be able to keep your health workers safe. Here are some intervention design considerations. Here are some suggestions about, as you've started to do your quick assessment and you've taken the previous slides' considerations into account, here are some things that you want to think about as you start to develop your intervention for IPC. You want to start with a couple of your challenges. You want to identify key players who are going to be involved in the success of these strategies. You want to bring those players together and do a very quick small focus group with them. Get their buy-in. What are health workers going to do and be willing to do? I don't have to tell this group. There is not a nurse or a doctor alive who likes it when someone comes to them and says, you need to do this. So get a little bit of buy-in. See what health workers are willing to do and feel like they feasibly can do, and then meet them in the middle if need be. Develop a short list of strategies that you think are going to be best to implement your IPC evidence-based practices. One of those strategies must be education. We already know that we have to do some form of training or instruction. Then you want to identify 2 to 4 other strategies that you want to use in addition to educational strategies to build a multimodal intervention. You want to put those strategies in a group. You want to review them to see if they make sense based on the context of your challenge and your healthcare facility. Begin to think about how you want to implement those strategies, particularly around the communication of the strategies. And then, of course, be ready after you've implemented to do just a quick assessment to make any kinds of changes or modifications as you go. So let me show you what this might look like. Here is an intervention design that I did for a previous epidemic. Our IPC challenge was screening. We were having a heck of a time screening health workers when they first came in to their shift and when they were leaving their shift at the end of the day at the healthcare facility. So we knew that we needed to introduce screening. We also knew that we had to have an education strategy. We had to inform our health workers why we were screening them when they started their shift and when they ended their shift and why it was important. Then we decided, how are we going to educate them? What specifically are we going to talk about? So we had to think about, do we want to do a training? Do we want to show them the screening form that we're going to use and do a demonstration? How do we want to promote these strategies? Then we had to decide, how are we going to make sure that our actual challenge is being addressed? So then we decided, how are we going to monitor? How are we going to evaluate that screening is actually happening? And then we said, we're going to have to use a restructure strategy too, because we don't have, at the beginning of this epidemic where we used these 3 strategies, we didn't have a triage bay. We didn't have a screening area. So we said, we're going to have to restructure. We're going to have to create a space somewhere in this healthcare facility where we can effectively screen. And because we've never had nurses or doctors at a triage bay before, because we haven't been doing triage before this epidemic, we're going to have to assign certain nurses and physicians to work the triage bay and away from, let's say, their normal clinical duties. So what we did for this epidemic to promote IPC screening was we decided we had to do a training to inform individuals about the screening. We showed them the triage, we showed them the screening form, let them see it. We demonstrated to them how to use it, and then we had them demonstrate to us how to complete it. Then we restructured and we created a triage bay very quickly with 2 plastic chairs and a table. It doesn't have to be sophisticated, folks. 2 plastic chairs and a table, a thermometer, screening forms, waste bins, very minimal requirements for a triage bay. And then we assigned certain nurses from certain wards. We took 1 nurse from each ward and assigned them to work the triage bay and created a schedule for them. After we started implementing this screening mechanism, we then created a very simple checklist to see if the actual screening process was, 1, being effective, and if we were actually able to more rapidly identify health worker infections. All right? So this was one example of how I've utilized this particular practice to keep health workers from getting the actual disease during an epidemic. Another way that you might do this is, let's say you realize that you want to implement screening and you want to do education and restructure quality management, but you also realize, wait a second, my healthcare facility has no policies or very limited policies about how screening should be conducted and where exactly these policies should be kept. Then you can add a policy strategy to your arsenal and implement that as well. So the goal here is that the key to keeping health workers safe during an epidemic is that you have to implement more than one strategy. So to be able to improve IPC. So I'm wrapping up time here. I'm going to just show you very quickly. I won't go through it extensively. These next few slides are just a few technical tools that we've developed at Afro around healthcare worker surveillance tools. There are 3 tools that you can use to assess your national COVID-19 policy for health workers. So that's what this slide is talking about. Here's the algorithm for that tool. The second tool that we've developed is exposure, risk assessment exposure for health workers. So doing active surveillance at your healthcare facility. And here's the sort of the algorithm for that. On this link right here, you can click on this link and you can actually start to use this tool in real time if you have a suspected case or an actual exposure at your healthcare facility. This particular tool is actually used through the Kobo Collect database platform system. So you're happy to use that tool in real time. And then the third tool, we call it tool 4, but it is after you have had a confirmed and identified health worker COVID-19 case, going back and doing a case investigation to be able to see where exactly did the exposure happen and where were some of the IPC gaps and challenges that were contributing toward the exposure and case. And then here's the algorithm for that as well. And then of course, here is the link to the Kobo form that you can use also. So the last thing is to make sure, and this is my last slide, is to ensure that you're creating a culture of IPC within your country and within your healthcare facility. I know here in our region, we are really rapidly learning about IPC right now because of COVID-19, but here are some important things to think about to make IPC very institutionalized at your particular healthcare facility. And that's to make sure that these actual policies are visible, they're available, they're up to date. You want to make sure that you're constantly engaging your leadership and getting support. Make IPC second nature. Do the same thing every time. Making IPC practices easy and the most effective choice for health workers will ensure that they actually comply more with it. Make sure that you mentor your colleagues and make sure that you're encouraging your colleagues. Always make sure that new employees are very aware of IPC practices. During an epidemic, we have lots and lots of new recruits to help us with these initiatives, and a lot of times they don't necessarily get as much onboarding as they need. Monitor and evaluate, reduce other healthcare associated infections at the same time. Because remember, This COVID-19 pandemic is gonna go away, but we are still going to wanna make sure that we institutionalize a culture of IPC so that we don't start having increasing numbers during the pandemic of healthcare acquired infections, and then of course, after the pandemic. Prepare for emergencies and use these emergencies to invest in IPC continuity of practice and make the right behavior the easy one. If putting alcohol hand rub at the point of care makes it easier for health workers to engage in hand hygiene, make the easy option the safe one and the best one. Thank you so much. As I had mentioned, if you want a complete list of these strategies, here is the actual reference for an exhaustive list. And here is my contact information. If you have any additional information or questions that you would like, please feel free to contact me. And thank you so much. I appreciate your attention today.
Thank you very much, Amy or Edith. We will get back to some of the questions afterwards. I would like to introduce Dr. Andrew Lukaka from Malawi, that's going to tell us a little bit about the country perspective from Malawi. I handed it to you, Dr. Andrew.
Thank you very much, Ada, and thank you, colleagues, for spending some time to listen to very wonderful presentations. I'll be sharing my screen, and I'm making this presentation on behalf of all colleagues in Malawi, government, public, private, donors, implementing partners, and health workers who are also participating in this presentation. So I'll be giving you an update on what has been done in response to COVID-19 as far as infection prevention is concerned. So I will tackle essentially on a number of issues, a background, giving you the whole COVID situation in Malawi, and also what has been done, challenges, as well as next steps. Just briefly, Malawi has got a projected population of almost 19 million, and we have 29 healthy districts located in 3 regions. We border with Zambia, Tanzania, and Mozambique. We have almost 10,000 facilities. That's 9,498 facilities. This includes private NGO facilities, government-owned facilities, as well as faith-based facilities. And our health system is tied into 4 levels. We have community, primary, secondary, and tertiary level of care. So briefly, also just want to highlight events as far as COVID-19 is concerned in Malawi. We've had, as we're aware, from December, WHO made an alert, and January 2020, we had a declaration by WHO of COVID-19 as a public health emergency of international concern. Specifically for Malawi, we declared the COVID-19 as an emergency, even way before we started reporting cases. That was in March 2020. Our first case was reported on 2nd of April 2020. And from April 2020, we've seen increased numbers of cases as well as deaths. And we had the COVID-19 rules being gazetted. So we have a registration to support implementation and reinforcement of all the COVID-19 preventive measures in Malawi. Situation update as of 6 October. We've had the 5,796 confirmed cases, with 4,549 recoveries. I must indicate that our testing capacity, so far we've conducted 54,000 tests, but our testing capacity is quite limited at the moment. And in terms of mortality, we've had 180 deaths, one maternal death so far reported. So when you look at a downward trend, clearly you can see that in Malawi, we started reporting spikes of cases in May, and we had the huge spikes in June. And this is a period when we had the campaign rallies preparing for fresh presidential elections. And clearly you can see that immediate after elections, we started having huge numbers of cases as well as deaths that were being reported. As of 6th of October, we've had 570 healthcare workers who have been infected. We had also 3 deaths, unfortunately. We've had 27 districts that have been affected, mainly health workers that have been affected. So I would say that out of 29 health districts, or 27 have been affected, almost all the entire country has been reporting infections among healthcare workers. And when we come to age, you see that on a median age has been 35, and the majority of the healthcare workers have recovered COVID-19. We made a projection just to show distribution by cadre. So majority of our cases are essentially nurses, followed by community healthcare workers, those are HSS, health surveillance assistants, and clinicians. So we had a number of interventions starting from point of entry in Malawi. So we reinforced IPC measures, hand washing. We're among the first country to introduce hand washing at the airport, not use of hand wraps. Also, screening for travelers has been reinforced. Majority of our travelers of late are coming from South Africa, and these are returnees. Some of the Malawians who stayed longer in South Africa, they are returning back. At the community level, Malawi has got a strong community health system supported by community health workers who are called health surveillance assistants. They are trained to provide health promotion, health education, as well as community sensitization and screening. So we've been reinforcing use of cross masks at the community level, as well as social distancing. We've developed guidelines and the standard operating procedures for COVID-19. I must indicate that with the nature of COVID, evidence coming time and again, it has been very difficult to disseminate the guidelines because of the nature of the evidence that is coming in. So some of the new interventions that have come into the guidelines include the mandatory use of face masks, including also management of dead bodies, mainly for COVID-19, safe burial for COVID-19, disinfection of premises, including schools. So all these have come into the new guidelines. Also, we've intensified on the promotion of proper use of cloth masks, as well as proper disposal in the community. So these are just some of the posters that are mounted in various places to promote proper use of cloth masks. We've had a number of capacity building activities for healthcare workers. We've so far trained over 400 trainers in infection prevention across the country. And over 2,000 healthcare workers have been trained across the country. And the trainings are still ongoing, being cascaded down to community level. A number of challenges have come out. First of all, we've had challenges with assessments, as well as the monitoring of IPC measures, mainly due to limited funding. We had so many interventions to be conducted at the same time, and almost no time on the resources to do monitoring as well as assessments. We've had also poor adherence to IPC measures. I must indicate that as the numbers are showing that they are going down, the trends are going down, it's also becoming very, very difficult to reinforce and for communities to adhere to the infection prevention and control measures. We've had also misunderstandings, mainly on the burial procedures. At the community level, health workers wanted to bury COVID-19 bodies, just like the way they were burying Ebola. And this really created tension. We've had the huge tensions, including health workers being ambushed, in other cases injured during burial. So this has been really a big, big issue. Virtual trainings also have been, because of the social distance, limitation in terms of number of gatherings. So we've been relying on virtual meetings, virtual trainings, but connectivity has been a challenge, mainly in rural areas. So we want to move forward by ensuring that the community and the public doesn't relax because of the figures that are coming out and the trends. I want to also conduct a facility assessments to ensure that adherence of IPC measures are being taken. UNICEF is already committed to support, as well as other stakeholders. Training of healthcare workers, want to commend the African CDC who are supporting the trainings to take place this month. And essentially these trainings will be catalytic also. We are strengthening on training trainers of trainers who can cascade the trainings going down to districts as well as community. I want to strengthen integration on WASH in facilities, IPC, as well as AMR and microbial resistance, and also facilitate continued community engagement on IPC adherence. I want to acknowledge all partners and donors who have been providing support to Malawi on provision of personal protective wear, mainly for healthcare workers, as well as the community. So I want also to commend all partners, colleagues, health workers, who have been part and parcel of success in Malawi. Thank you very much for your attention, ladies and gentlemen. Thank you.
Thank you very much, Dr. Likaka. It was brilliant and quite nice and clear to see what's happening in Malawi. I do appreciate that. I want to take some questions that's in the question and answer box. And I'm going to start at the beginning. And this was for Dr. Idoawa. They ask if we have data on the relative testing across the African region. Dr. Edouard, if you or anybody on the panelists can respond to that. Over.
Sorry, Anna, I didn't get the question, please. Can you repeat?
They ask, do you have data on the relative testing across the African regions?
Obviously, we do. And yes, in terms of testing, the number and data concerning the infection, the cases, and also among the health workers. Though it may not be totally complete, but we do. And I'm not sure if Dr. Mohammed is on the call. Maybe he may want to over.
Thank you very much. I'm on the call, but I missed out the question. Can you please repeat it?
Dr. Mohammed, they ask if we can tell them if we have data of the pre-testing, the relative testing across the African region.
Okay, data for COVID-19 testing?
Yes.
Yes, we do have that data, and if what we can do is to invite the head of division of lab to maybe in our subsequent webinars to do a comprehensive presentation so that the participant can see how this data relates in the different countries and regions of Africa. What we know is that Southern Africa region is doing the highest level of testing of all the regions, followed by Northern African region, and the West and Central Africa regions are the ones doing the least number of testing. But if participants want a more detailed presentation, we can ask the head of division of lab to come in the next webinar or any other one that we can fix to give a more detailed discussion on that. Over.
Thank you very much, Dr. Mohammed. I want to put this forward to Ebeth and maybe to some of the WHO on the call. The question was, now the WHO have shown support that COVID-19 is transmitted by airborne, how will this affect or inform the IPC strategy and precaution measures? Over to you, Amy.
Thank you, Anna. So one point of clarification is that right now the WHO acknowledges that there is some minimal evidence that suggests that COVID is airborne, but the reality is that the actual evidence is very limited and really can only be transmitted through particles in the air within sort of enclosed spaces at certain distances. So really, WHO strongly still suggests that the precautions that we are taking right now for COVID-19 that are generally considered droplet precautions, if you will, are still going to be the focus of your IPC interventions until we have further evidence that is more strongly suggestive that this is an airborne route of transmission. At the moment, the scholarship, as I had mentioned, is very, very limited, and the sample sizes are very small. So when thinking about your IPC interventions, you're still going to want to focus on those that have been consistently promoted for droplet and contact precautions. So, wearing a mask when appropriate, physical distancing, hand hygiene, et cetera, et cetera. Thank you.
Thank you, Edith. There's one question for Dr. Likaka. They said very good presentations, but they may be need to do more on intensified community education on COVID-19. How do you want to respond to that, Dr. Likaka?
No, thanks very much, Anna. I think that observation is very, very true. But this is now where data can talk. Data can be a tool of advocacy, great advocacy. we are challenged that people want to be driven by data. When they see us reporting 1 case a day or no case, 3 cases a day after testing 200 people, and even the people that we are testing specifically screened highly, those that have got, for example, symptoms. It becomes really very, very difficult to convince the public to adhere.
So the meeting is
Yeah, it becomes very difficult. It becomes very difficult for the public to take up. We have a very surmountable task ahead of us to make sure that the public understand the data. I must also highlight that 85% of our population lives in rural areas. Education rates in those areas are quite low. And in terms of numbers, people that have been affected or infected with COVID in rural areas is quite low than in cities. So life is almost normal in rural areas. So to bring the messages, I think data are needed to really work on. I see the question about testing capacity. On average, I think we are testing about 250 at the moment per day. It's very difficult to talk about the positivity rate because we are screening. We are targeting only those that have got symptoms, signs and symptoms of COVID-19. So I think coming on with the issue of positivity rate may not be realistic, but we've seen a positivity rate ranging from 6 to 10% over the past 3 months. Thank you very much, Anna. I've got Dr. Musopole, also Dr. Owen Musopole, who can probably come in and give insight to the situation. Thank you.
Thank you, Dr. Likaka. We will give him a chance just now. I just want to put this over to Africa CDC or even to WHO. The question was that, is there a surveillance system for ensuring we capture all healthcare workers who get COVID-19, particularly with limited testing in most of our African countries? Over.
Anna, can you repeat the question again?
She asked if there's a surveillance system for ensuring that we capture all healthcare workers who get COVID-19, particularly with the limited testing that is done in most of the African countries. Do we have a surveillance system?
Okay, thank you very much. For Africa CDC, we depend on the surveillance system by member states. And obviously, surveillance system differs from one member state to the other. And we depend on member states to give us data on healthcare worker infections. And that's what we've been using so far. Obviously, it will be good to have that data, but we know that different member states are at different levels of maybe sophistication in terms of data collection and the number of variables they collect pertaining to COVID-19. However, the ones we have are the ones we've been presenting in different fora that, including on this forum. I don't know if WHO are on the panel, they can give an idea. I think Ibet can talk about that. Over.
Thank you, Dr. Mohammed. Ibet?
Yes, so you're correct. We do have a challenge with sort of the denominator in terms of overall cases, but for the most part, there have been surveillance systems put in some derivative form or another in each of the member states to be able to track those infections. So for example, like WHO Afro, for those member states who have been willing to share that information, we have been compiling that into a database to keep track, particularly of those areas where we're seeing new clusters of health worker infections that are popping up, and then trying to provide guidance on why it seems to be that there is an increased number of cases in those particular areas. So as much of a comprehensive system as it can be, that information is being collected over.
Thank you, Amy. Dr. Likaka, you said you had somebody that could actually also come in on the previous question. If you want to bring them in, if it's possible, we do still have time for that.
All right. I wanted to bring in Dr. Msopole, but seems it's tied up. Anna, there is a question about IPC in schools. Yes, we've set up IPCs in schools, but I must indicate that the structures, we've tried as much as possible not to introduce new structures in the schools to ensure sustainability. So we've integrated IPC within the school health and nutrition programs across all schools in Malawi. And we have teams of assessors. So these are working quite well at the moment. I must indicate that schools are not fully open for us to see the real impact of schools in Malawi. We only allowed specific and particular classes as well as schools to operate. Mainly those that had the exams, those that were almost finishing, we allowed them to open schools. Most of the schools will be opening in the next coming 2 weeks. We anticipate lots of challenges when schools open related to IPC. Hand washing structures are not really adequate. We have a huge deficit of hand washing, even water, availability of water in schools, social distancing. Amenities that are available in schools, most of the schools are not really adequate to sustain the drive and the prevention of COVID-19. Finally, it's about capacity building. We set up these IPC structures in the schools at the time when we are about to open in schools. So the time that we had to train them, it was limited, as well as resources to support that. So how do respond in that manner? Thank you.
Thank you very much, Dr. Likaka. I want to hand over to Karen. She wanted to also just comment on the airborne transmission issue. Karen, over to you.
Yes, good morning. I have obviously had many years of experience with TB and TB infection control, the quintessential airborne pathogen. And I think this is a very important question about COVID being airborne transmitted. I think you have to remember that for IPC, many of the most important interventions to protect patients and healthcare workers have to do with administrative controls, specifically outdoor triage. And from the beginning, WHO, Africa CDC, and we at Resolve to Save Lives have strongly advocated that all patients coming to a facility should be triaged and screened outdoors. So this was because of droplet transmission, but of course it applies equally to airborne transmission. And I think that really the only major difference has to do with the face mask that is worn for airborne transmission when you really do need an N95. But this would only be in circumstances, as Ibex said, where there really is evidence that airborne transmission is going on. Remember, PPE is the least important of the pillars of IPC. Administrative and environmental changes are so much more important and also in a way easier to do. And moving things outdoors, making sure that within a hospital setting, all windows are always open, are some very easy things that will apply both to droplet transmission, droplet transmission of COVID as well as airborne. So I think that the airborne transmission issue gets people extremely upset. And I don't necessarily think that that's appropriate right now. I think we should double down and implement the things that have been recommended for COVID from the beginning. Thanks.
Thank you, Karen. And I think with that as well, the last questions we had actually touches on that as well, where they asked, with the reduction in the incidence of COVID-19, what level of personal protection is the Africa CDC and WHO advocating? I have challenges providing advice to those who want to adjust level of protection. So Karen, maybe if I can hand over to you and to Dr. Mohammed, maybe we can just touch on that question. Thank you.
Again, Anna, the voice was breaking a little on my end. Can you repeat?
They were asking what level of protection are we advocating, because people want to adjust the level of protection now that the cases, the incidents are dropping.
Let me try to answer, because I did not hear very well. But I think at every stage of the pandemic, we should continue to maintain the highest level of infection prevention and control, because though we may be seeing cases dropping in some parts of the continent, but in other parts the cases are actually rising, and this is not time for complacency, because we are still putting the data together to be absolutely sure that we are seeing a true epidemiological drop in number of cases, and not just an artifact or this. And so I will advise that we continue to maintain the highest level of infection prevention and control that we've been observing, continue to use our masks, hand wash, and we hope this will be an enduring, especially the respiratory hygiene, the hand washing, and other aspects of the IPC that we've gotten used to over the past 7-8 months. We hope it will be an enduring aspect that will continue even after the COVID-19, because let's face it, we need to protect ourselves against other infection, not just COVID-19. And who knows, lessons history have taught us that we are never far from another emerging infectious diseases that could shock the whole world again. So it's important that we make this as a regular habit for us, and keep us protected all the time. Over, Anna.
Thank you, Dr. Mohammed. Karen, I don't know if you and Amy want to maybe say something on that as well.
Yeah, I agree with what Dr. Mohammed said, 150%. I think, as I said, many of these issues come up with tuberculosis. Cough etiquette and hygiene are permanent parts of IPC. They should always be observed. In tuberculosis infection control, we've been stressing this for many, many, many years now. And I think that hand hygiene is obviously standard precautions for anything in any healthcare facility, and that also must continue to be adhered to. I think the issue of masks, until we know for sure that COVID is gone, I would recommend continuing to wear surgical masks. So much of COVID transmission happens in the pre-symptomatic and asymptomatic phase that you really cannot be certain until we know for sure that we're on top of this. Thank you.
Thank you, Karen. And I think, yeah, like we all said, I think we all agree on that. It's important that we just stick to what we've been told, everybody, until we know exactly what's happening. But as Karen also said, remember, in IPC, it's not just about what's happening now with COVID, but also other infections, so standard precautions, and then the additional precautions when we know the type of disease. And with that, unfortunately, we don't have any more time. If you do have any more questions, you can still put it on the Telegram, which will be looked at, and we can try and answer you, or we can get hold of the Africa CDC, or I can individually, and we can try and see how we can help, or even WHO. I'm sure they're all available for this. So I want to thank everybody, and I want to just remind you there will be another session next week at the same time, and then every Friday there will be the French session as well for the French-speaking people. Thank you very much, and have a brilliant day. Thank you. Goodbye.
Thank you.